Great. Oh, I'm too short for this. If I stand on tiptoes, is that better? Right, well, really, I'm a social worker, masquerading as an academic. But when I was a social worker, I felt like I was masquerading as a social worker, because I spent most of my time driving around the townships of South Africa completely lost and trying to work out which mountain I should be aiming myself at. And now I work with a fantastic team of postdocs and PhD students who mysteriously won't get in the car when I'm driving. But I'm still trying to work out why. So, what I'm going to talk to you about today is really a puzzle. Because I think that this field, and what I've seen and heard today at this conference, is that we're at the very beginnings of a fascinating new field. There's a really quite well-established field of economic strengthening, asset building, finance, which is done generally by a set of finance and poverty people over in one side. And on the other side, there's the OVC people. And we're doing our own work, often, as Fred said this morning, more focused on psychosocial needs or health needs than other things. And really what's so innovative about this is that it's bringing together and trying to understand how these different worlds might be fitting together with the very clear, direct aim of benefiting children. But what I want to talk to you about today is really about one small aspect of that, which is how might and does economic strengthening prevent HIV risk behavior and HIV infection amongst adolescents. Now, this is an area in which, unfortunately, we are not doing so well. HIV prevalence is going down, or HIV infection rates are going down throughout Sub-Saharan Africa, except among adolescents. We're seeing rises in 50% in the last 10 years in adolescent AIDS deaths, and we're seeing about 160,000 new adolescent infections per year. Unfortunately, meta-analyses of randomized and non-randomized trials are showing that our traditional behavioral interventions, to which we've been pumping billions of dollars for the last 25 years, don't seem to be having the kind of effectiveness that we would like. They are showing effectiveness in other groups, particularly MSM, groups in the West, but in Sub-Saharan Africa, amongst adolescents, we're just not seeing as much effect as we need to be reducing this level of risk. So where did we come in? Rather accidentally to this. We were conducting a study that was a wildly overambitious collaboration between all of these partners. And you can see just to the bottom right hand, there's a very blurry picture of our teen advisory group. They're 14 AIDS-affected kids who advise all of our programs. And we're just in the process of finishing a national longitudinal study, where effectively we selected in 3 provinces, rural and urban areas. We randomly selected census enumeration areas or tribal authority areas in places where that didn't work. And then we interviewed every single household with a child aged between 10 and 17. And what we were trying to find was what the impacts of being in an AIDS-affected family were. That wasn't necessarily what we ended up using the data for. And I'm happy to answer methodology questions if you've got them. This was some of the pages from our questionnaire. If anyone here is an intellectual property lawyer, please shield your eyes. But you can see one of the things that our teen advisory group recommended was that we make our questionnaires as engaging and teen-friendly as possible. This is designed on 17 magazine, for anyone who reads that. And it was done in the style of a kind of teen magazine quiz. We originally had a picture of Beyoncé in a very low-cut top on the front, but the teenage boys liked it too much, and we had to change it. So what did we find? Some of the key things we found were very clear linkages between family AIDS, poverty, and HIV infections. So we see very clearly, we all know this, to the right is AIDS-affected kids, to the left is non-AIDS-affected kids, much doubled or trebled levels of poverty. What's interesting is you look at the far right, you can see a group called AIDS dual-affected. That's kids who have both lost at least one parent to HIV/AIDS and are living currently with an AIDS-sick parent or caregiver. They seem to do worse on kind of everything than singly AIDS-affected kids. We also see very clear cumulative effects of poverty and other nasty outcomes of parental AIDS on HIV risk behavior. So if you look at this study, we see that to the left, that a girl who lives in a healthy family, she has enough to eat at least 5 days a week and doesn't experience any kind of abuse at home, has just under a 1%. It was a 0.9% chance of having transactional sex. If you look to the right-hand side, you can see that a girl who has one or more AIDS-sick parents or caregivers is experiencing abuse and doesn't have enough to eat at least 5 days a week, has a 57% chance of having transactional sex. We know that transactional sex is one of the major vectors of HIV infection amongst girls in Sub-Saharan Africa. This also tells us something about some of the motivations and reasons behind what might be going on for these girls. If you read about transactional sex in the media in South Africa and also in much of the qualitative literature, it's about luxuries, it's about peer pressure, it's about having an older boyfriend who can help you buy handbags and lipsticks and cell phone vouchers. That's not what this suggests. This suggests that transactional sex is being driven by extreme social and economic vulnerability, and suggests that our responses to trying to reduce things like transactional sex might need to be targeted on social and economic vulnerability. So what are some of the pathways that we can look at to HIV risk? This is structural equation modeling. Are people here familiar with structural equation modeling? It sounds so fancy. The first time I heard it, I thought it was super clever. What it essentially is like throwing a bunch of regressions all up in the air at the same time and seeing how they link in with each other. And it's not actually that hard to do. So what we found, we looked at what might be the pathways between being AIDS-affected and HIV risk behavior. This is on our national sample of 6,000 kids. So what we see is that being AIDS-affected, being AIDS-orphaned or having an AIDS-sick parent leads directly and indirectly into poverty, which itself leads directly into raised levels of child abuse and stigma. We know this. If you're stressed out, if you don't have enough to eat, you're much more likely to be hitting your kids. And those three, I think of them as the kind of lurking evil three of poverty, stigma, and abuse, increased psychological distress. Through that, we see increased education risks and directly into HIV risk behavior. So what might be some of the solutions? Well, one potential solution, and this is really pushed by the World Bank, and as I speak about this, Michael will start to go pale with horror, is cash incentives. This is a trial that was done in 2012, I think, or 2012 by the World Bank. They're also doing similar ones in Lesotho and in Swaziland. But essentially what they believe is that you can incentivize safe sex through using money as a behavioral nudge. So what this trial does is it's for young people in Tanzania. Every 4 months you go for an HIV test, an HIV and STI test. If you get a negative result, you get either $10 or $20, randomized to different conditions. If you get a positive result, if you have an STI, you get nothing. So the idea is it's incentivizing you, your decision, cash or sex, you go for the cash. The results showed that for $20 a month, sexual activity did reduce, STI prevalence did reduce. For $10 a month, it didn't. I'm not sure what that's telling us. What's interesting is that when they tried this in Malawi in a trial where the incentives, they were giving girls an incentive for attending school, and Michael actually showed this study as well, they did find improvements in school attendance and reductions for those who attended school in HIV infection, but it was the same whether they got the grant conditionally or unconditionally. So the unconditional grant did exactly the same job. Why does that matter? Well, we know that conditionality costs about 1/3 additional in terms of just sheer cost of the program. So we need to think about what might be the most helpful thing here. So around this time, other groups, particularly UNICEF and EPRI, Michael's group, were starting to think about unconditional cash transfers and how they might link in with HIV prevention. So where I came into it was at a meeting in Addis Ababa. There's Addis on a particularly quiet, calm spring morning. And I was there giving a talk for a Save the Children symposium at a conference. I was sharing my room with 2 large cockroaches who are featured in the middle. For anyone who knows South Africa, I named them after 2 of our former prime ministers called Verwoerd and Botha. And while I was there, UNICEF, the then head of social protection at UNICEF, came to me and asked if we could do any analyses on our data to try and understand whether social protection was providing HIV prevention benefits. Well, it took about 18 months for me to finish collecting the data and then work out how the hell to do this. And what we eventually did was something called propensity score matching. Propensity score matching is another fancy term. What it basically is a statistical way of trying to recreate or simulate a randomized trial when you can't do a randomized trial. In this case, we have in South Africa a child support grant. Some people get it, some people don't. And this allowed us to simulate those two groups into equalized groups. So what you do is you control for loads of things, basically. It's a fancy way of saying controlling for as much as humanly possible. And then a particularly either wise or nasty reviewer at The Lancet made us do the entire thing again in multivariate regression. And Melissa, sitting over there, sat for an entire week in a cafe in Oxford while we redid it all. But what were the results, more importantly? Firstly, we found very clear results. And we found clear results on incidence of HIV risk behavior, which, of course, is much more reliable as an outcome than prevalence. So we see, firstly, that girls who get the child support grant in their family have half the rates of transactional sex than girls who do not get the child support grant. That's the same for incidence and prevalence. We also see that girls who get a child support grant in their family have 2/3 less rates of age-disparate sex, that's sex with someone more than 5 years older than them, than girls who do not get the child support grant. It didn't work for other things. It didn't work for multiple partners. It didn't work for having sex when you get drunk. It didn't work for casual sex. It didn't work for, that was it pretty much. It didn't work for boys at all. It didn't seem to change the dumb stuff that teenagers do. What it did seem to change was girls' choices and capacity to make a decision about who they wanted to have sex with. They didn't need to have sex with someone who was going to pay the groceries or pay their school fees. That seemed to be what was going on here. Around this time, another study came out by Sandashu Handa, which found very similar things in the Kenya OVC program. So it seemed like there was starting to be some really valuable data suggesting that these unconditional cash transfers might be doing something really useful for HIV prevention. But there was a big argument back with the World Bank. And although it in some ways wasn't a very helpful argument, David Wilson, who was one of the heads of the World Bank, said a really valuable thing to me. He said, it's clearly not enough. You're doing something about transactional sex, yes, but it's not enough. It's not hitting boys, and it's not hitting all the HIV risk behaviors. So after kind of grumbling to myself quite a lot about this, we went away and thought, okay, so what can we do to try and maximize the effect of these cash transfers? And one of the things that we looked to was the adverse childhood experiences studies, and I'm sure lots of you are familiar with them. But what this part of the study showed, basically, was the more bad things that happened to you in your childhood, like being abused, having a parent in prison, having your parents divorced, the more sexual risk behavior you have as you grow up. So while sitting at a PEPFAR meeting, listening to a brilliant presentation on this, I suddenly thought, well, what if you turn it upside down? If you give them more good things, do you get HIV risk behavior going down? And around that time, Jason Wolfe, who's sitting over here, sent me about 5 papers by Fred, saying, have you read these? And I had read them, but I hadn't put 2 and 2 together. And if you look at Fred's work, one of the key and core assumptions behind it is that you're combining an economic improvement or a perceived economic improvement in the future with a family strength building approach. So we started to think, if you add economic approaches to family support or social support, do you get better results? Well, what we did was we then went back to our national sample. And we're not creating new interventions in this. We're looking at existing interventions that these kids are or aren't getting. So we went through all the interventions that government and NGOs had asked us to include in the questionnaire. And we've got all these lovely interventions that kids can get. We then, in our sample of 6,000, got rid of the ones where less than 100 kids were accessing them regularly. And that left us with this. which was a bit of a surprise and a bit of a blow to our analysis. Unfortunately, things like home-based carer, we only had 3 kids getting them consistently over a year. So there's something to be looked at in that. Anyway, so we're left with what we've got. We've got child-focused grants, we've got free school meals and food gardens on the economic side, and positive parenting and teacher social support on the sort of care and support side. So we called them cash and care. And we asked whether singly economic support or combined cash and care might be influencing incidents of these sexual risk behaviors. What did we find? We find that for girls, cash alone gives us a reduction of around 40% in incidence. But if we add cash to care, we get a halved rate of incidence. For boys, it's much more striking. Cash alone doesn't seem to have any effect on boys, but cash plus care gives a halved incidence rate of sexual risk behaviors. So the next question that came up as we sat in a UNAIDS meeting in Geneva, and actually as I sat watching one of Michael's presentations, was to ask how? How does cash plus care influence HIV risk behaviors? And actually, I've just spent about 4 months on this analysis, and I showed it to someone who said, I really don't think this is important. You should just be not focusing on this. So tell me what you think. But we tried to understand what might be the mechanisms by which it might work. And this is where the slides are going to get less pretty because we're still work in progress here. So we started to try and understand what's causing this HIV risk behavior. And what we clearly see is that we've got this kind of structural deprivation, bad economic and family circumstances, which leads straight into a set of kind of mediation outcomes. This is a multiple mediation model. And you can see that these are some of the things that we saw in the structural equation model before, but we're seeing that those all lead on. Anyone who's worked as a social worker recognizes that this is the processes that we'll see. And these seem to lead directly into child HIV risk behavior incidents. We also see that cash and care, independently and together, both impact those intermediary outcomes. And all of those lines are significant lines, and we've got a direct line from cash into lower incidence. I suspect that's actually just going through an unmeasured mediator there that we haven't got. But what we can see is that there are direct mediation pathways going through. So what seems to be happening, and here I just kind of lumped everything together because I was trying to make the tables look a bit clearer, but I lumped them together in the analysis as well. What we seem to be seeing is that cash and care independently reduce this kind of, they interrupt this pathway, whereby structural deprivation increases these family and psychosocial risks. And by doing so, they interrupt the pathway to HIV incidence. I think we've got loads of work still to do on this, but I'm hopeful that understanding how these pathways work can help us understand how we should be using cash and care programs, how we should be thinking about economic strengthening in order to achieve these HIV prevention benefits. So just as I'm finishing up, some of the new things we're trying. We're currently working on a child abuse prevention program for AIDS-affected and other families in Sub-Saharan Africa. It's an attempt to do sort of free versions of what exists in the West, but is very expensive. And one of the things we're increasingly realizing is that we need to add in an economic strengthening component. We don't yet know what that is. And one of the challenges of our economic strengthening components that we know about now is that they tend to be very long-term. They may not fit so very well with shorter-term programs. This is a 4-month program. They may not fit so well with those kinds of programs. And if we are going to be thinking about combination interventions, we do need to think about time and cost of combining those programs. So any advice and thought really, really gratefully received on this. And fast, because we need to start the randomized control trial quite soon. The other study that we're doing that I hope can work with Fred Fred and Claude's program to help us understand how to improve HIV adherence is this study. It's a longitudinal survey of between 700 and 1,000, we don't know yet, adolescents in South Africa who are all HIV positive to try and understand predictors of adherence and use of sexual and reproductive healthcare use. Now, one of the key things that the UN, UNICEF, and UNAIDS have asked us to test is whether accessing social welfare grants and other kinds of support services can actively improve adherence. We just don't know yet, but hopefully that this data is going to help us to understand how we can best improve and how we can combine those kind of services with intervention programs such as you're trying in Uganda. So to end, what do we know and what are some of the research gaps? We do know that unconditional government cash transfers do seem to reduce adolescent HIV risks. We do know that family savings schemes from Fred's work reduce adolescent HIV risk-taking attitudes, and it looks like soon we're going to have data from that on whether we're seeing actual reductions in behavior. We can see that integrated interventions seem to have greater effects, although we don't yet really understand enough about how we integrate those interventions. And Claude and I were saying earlier that the real implications of testing this is four-arm randomized control trials, which is like the prospect of having quadruplets in terms of thinking about the ease and grey hairs that it'll bring. I think one of the most important things we do know, though, is that these programs do show effectiveness in Sub-Saharan Africa, both in randomized control trials and in the kind of real-life, messy world of government and NGO programs. That's really important if we're going to think about scaling up. But what are some of the real research gaps? And I struggled here. I started off with 7 slides of research gaps, and I forced them into one, but although I had to mess around with the margins to make it fit. So what are our key questions? Should we be thinking about cash transfers or savings schemes, or both? Should we be thinking about which combinations of cash plus care work best? Should we be fitting school feeding programs with savings schemes? Should it be school feeding programs and teacher support? Should it be savings schemes and teacher support? This is looking like an 8-arm randomized control trial. Which subgroups benefit most and least? One of the things that we've learned from randomized control trials of other interventions is that you can get very strong moderator effects. You get programs that look great, but you find that only the wealthier amongst the participant group are actually benefiting, or only the younger or the older, or only the men or the women. We do need to understand this if we're going to think about scaling up these programs. We also need to think and understand how we're going to make sustainable programs. It's not going to be helpful for us to make programs which can then not be scaled up because they're too expensive or too complicated or because politicians just don't like them. If we want politicians to like them, we're going to have to think very strategically, like politicians, about how to make them think that they're their ideas in the first place. And then we have to predict who's going to win the next election. Because if you make the wrong guy think that it's their idea, then the next guy thinks that it was the last guy's idea. It's not always great. We also need to think about how we're going to reach the most OVC. What we saw from our study was that interventions that NGOs like PEPFAR, like Save the Children, and the South African government thought were reaching most of the OVC population were only reaching a tiny fraction of it. We need to work out how we make our interventions have wide coverage. Otherwise, we'll only ever have pocket impact. And lastly, we need to understand now what the barriers to uptake are. One of the great things I learned when I studied at Columbia briefly, when I finished my PhD, was that they were doing amazing innovative work. This was on completely different things. It was on uptake of HIV home testing. But they were doing amazing innovative work of trying to understand what the barriers to uptake would be before we even knew if the projects or the interventions were going to work. We need to have a parallel system of research, understanding what's going to stop these being taken up as we find out what's going to work. And lastly, to finish off, this is back to our teen advisory group at our last weekend workshop away, where actually we underestimated the amount of beds we'd need, and I ended up sleeping in the back of a pickup truck with 2 of my PhD students. But what I keep returning to is the time urgency of this work. It's about, I think it's about 9:30 or 10 o'clock in Sub-Saharan Africa, 10 o'clock in the evening. That means that by now, about 600 adolescents will have been infected with HIV today. We don't actually have the time to mess around on this. There's an imperative that's an ethical imperative to get this right, to work as a group, not against each other, and to understand what the best intervention is, not the intervention which agrees with our ideology necessarily. So, time's running out, but the great thing is that we've got good people working on it. And thank you to our funders, and thank you to you.
Collect some questions or do them one at a time?
Yeah, see,
let's collect a few.
But let's
Okay.
try. I'm on tiptoes again.
Hi, my name is Julia Shuhua. I'm Professor Ssewamala's student from Columbia University. I have two questions. I've been always interested in the benefit of unconditional versus conditional cash transfer, because I feel like having the conditionality within the service is as if that we're taking away the autonomy of the adolescents to decide if they get cash, how they're going to spend it. So I just wonder if you have any particular preference on either approach. And the next question is that it's interesting that from your 6,000 sample, you do have some children or family. They are receiving some cash versus care. But then in the causal inference world, there's a problem of self-selection into resources. So I wonder if you have used any way to address this problem in your study. Thank you.
So let me try and answer those quickly first. Okay, the first question about conditionality versus unconditionality. You've hit on the big question, one of the big questions that's coming out at the moment. And I don't think that my feelings on it are actually very relevant. And lots of people have strong feelings and thoughts and ideas about conditionality. But I don't think that matters. I think what matters is, what does the evidence show? Do we see greater impacts of conditionality than unconditionality? And if conditionality really costs 30% extra, we'd want to see greater than 30% extra impacts for it to be worth it. So to me, it's a simple empirical question. Does anyone want to do a meta-analysis? I mean, I think that's what we need to start looking at in quite a cold way, actually. Michael and I would disagree on that. You know, I have a less rights-based approach. Your second question about causal inference, spot on. This ain't randomized controlled trials. And myself and my colleagues at UNICEF actually have arguments about this, because I say what we need is more randomized control trials, and they say, well, randomized control trials are a bit fake, actually, and what we need is more propensity score matching of existing government programs. And there's a bit of truth to both. And of course we worry about causal inference. That's what propensity score matching tries to do, though. It tries to control out every factor that might predict whether you get the grant or not. Of course, you're limited to what you've got and what you've measured, so it's limited. Do worry if you ever see a propensity score matching model that's got less than about 30 covariates that it's controlled for, though, because you're very likely to get confounding there. It's not to say ours is perfect, by any means.
Great.
Thanks, Lucie. That was really great, as always, and an incredible amount of information that you're able to so clearly get out there. So I'm actually very intrigued by this cash plus care finding that you have, and it looked like you lumped a lot of different kinds of care programs, but not all care programs are equal, and not all interact with cash maybe in the same way, and I'm wondering if you have thoughts on that.
So this is a great question, and this is actually what Save the Children and UNICEF all want to know. They don't really want to know these concepts of cash and care and lumping the programs together. They want to know, do we add this program to this program in what configuration? What we're limited by is the fact that not nearly as many kids in the sample were getting these kind of positive things as we thought would be. So, you know, we assumed in a sample of 6,000 that we'd get loads, we'd have, you know, more than enough sample size for everything. We just didn't. And so that's really why we had to lump stuff together, to give ourselves enough power. But I think we've just got to try harder. There must be ways that we can test this. So hang on. Give me 6 months. We'll try and get this. You're right.
So Lucie, that was fantastic. I love to hear you present, and I really am intrigued, just like Claude said, around these kind of buckets of cash and carry. I do think you're right around the randomized controlled trials, and Susanna maybe is writing some of these down and taking notes, because I think that this is really important. But the other thing I'm learning from some of the work that we're doing here in the States that come out of Affordable Care Act are these things called pragmatic trials, that you really kind of create a map around what exists in your service system and start to pit those existing components against each other in as tightly a controlled way as we can. So I don't have the answer for you, but I love that you started to map what actually do these kids receive, and are there ways that we can study those combinations, and they might, the politicians might actually like us to study what they actually fund, and try to manipulate and control them. So I'm going to try to think about what pragmatic trials have for us. We'd love to work with you. Yeah.
Can you teach me how to do pragmatic trials, please, Mary?
Okay, can I rudely appoint myself to ask a question once, and then I'm going to come to you? So my question follows on your emphasis on some of Fred's work emphasizing hope, and we've heard about this today, the need to sort of think about care as a positive force. But then in your next slide, you had again the sort of mediating factors phrased as absences, so less stress and less of these things, right? And so, you know, in a way it's semantics, but what it leads me to is a very different thing that hasn't really been discussed today, that is always an elephant in the room for me at these kinds of conferences, which is religion. And we know in Sub-Saharan Africa in particular, but in lots of poverty-impacted places in the US and elsewhere, religion is huge, both in terms of social service access, but also in terms of psychosocial outcomes and things we also understand poorly that relate to outcomes of interest to us here. So I wonder, on the side of care, if you've done any thinking or know of anyone sort of working on this other aspect of social service delivery and
Yeah, it's a great question. So the history of me trying to study religion here is a history of mistakes. The first study I ever did, I just asked, do you go to church? How often do you go to church? Thinking this would be a great measure. It was completely useless. 98% of them went to church every day, couldn't do anything with it, you know, so high. The next time we started asking more subtle questions, and we tested the level of social support that kids perceived that they got from a religious leader. And I actually tried to look at the data recently, and it's weirdly not very good. So we're getting really low levels of social support from an emotional level, from a kind of material level, and from a sort of enjoyment and fun level reported from these kids from a religious leader. And I don't know if maybe we asked the wrong question. Maybe we should have asked about kind of youth people at the church or something like that. But it wasn't great data, and I couldn't do much with it. But I think it's really important. We do find that kids who get more social support from their religion, or feel that they get more social support from their religion, have reduced levels of anxiety. It doesn't seem to affect depression at all. And we've got to look at things still like behavior problems and stuff like that. I think it's a great question. It gets complicated when you start talking to policymakers. Especially in countries where policy and religion are mixed up in complex ways. But I absolutely agree. If it's something you're particularly interested in, we've got a whole bunch of data, you know, and it needs some proper look at to try and understand it. It's a great question. Okay, I'll be quick.
Well, thank you for not only your presentation, but for your work, because sometimes you don't know how far-reaching it is. So we learn from one part of the world, and then we try to use some of these lessons in other parts of the world. But I rather wanted to make a comment than a question. So you mentioned about the so now we already know that some of the intervention components work for certain issues, and it seems like, you know, a lot of people are now interested in combining different components, and how do we test them? And you mentioned that do we have to do a 4 or 8 arm, you know, randomized trials? And I thought Linda Collins out of the UPenn Methodological Center, she is promoting this MOST approach, so multi-phase optimization strategy to interventions, so which allows you to test using factorial design. You can test different components of the interventions and how do they work, because she's basically using this engineering approach to social and behavioral interventions, because they said when engineers are developing something, if they know that 10 things work, they don't try to combine them all together. They can say maybe intervention 2 and intervention 5 would work together, and you don't need the rest. So that's why I thought I would just mention it, because I think that would be an interesting way of applying this method to the work that you're doing, or many of us are doing, in terms of combining different components, but we're always limited by sample size, and it seems like this one doesn't require a huge sample size. We can just go away with the regular sample sizes we're using for like 2-arm trials.
It's a great idea, and this is something I'd love to discuss with people generally, because I'm really torn about this. You know, part of me thinks, let's use these great new innovative trial methodologies. I hadn't heard of that, this is great, but things like micro-trials and things. And then part of me thinks, it's so damn difficult to do an RCT in Sub-Saharan Africa. Like, it's an absolute bloody miracle if you just manage to have an intervention and a control group and you don't mess up too much. And then my worry is, the more complex you get, do you just end up much more likely to mess up? That's what I don't know. And actually, I'd love to hear if anyone's really successfully done one with a more complex design in Sub-Saharan. I mean, I know lots of failed ones, but I'd love to see some examples of successful ones and see what they did and learn from it. Because, yeah, that's just my worry, is that I would mess up. But maybe other people wouldn't mess up, actually. So, yeah, thank you very much.
I forgot to tell you my claim to fame. My claim to fame is that I was once Li Zhu's neighbor. Often the smartest people in the room are the project officers at our funding agencies, because they know things that we don't know. And they know things that we don't know because they hang out with all of us, and we hang out with our own people. And so they know what's going on in all these different places, and they see all these proposals come through, so they know sort of the newest ideas, and they know the best methods. But they also know what they don't have in their portfolio and what they want in their portfolio. And so if you go to conferences and funders are asked to speak, they're often the most popular speakers in the room, because people want to know what the funding priorities are of the agencies that they represent. So I am hoping that Jason Wolf and Susanna Allison are in the room. So Susanna Allison is with the National Institute of Mental Health, one of our institutes in our National Institutes of Health system here in the United States. She's a clinical psychologist, and her portfolio involves neurobehavioral and psychosocial studies involving children affected by HIV. And Jason Wolf is with the USAID Office of HIV and AIDS, and his portfolio works to improve the economic circumstances of families affected by HIV and AIDS. We're going to hear from Dr. Allison first.
Thank you so much for that introduction. I know this is a song that you've heard before, but it is really an honor to be here, and I just want to thank Fred for inviting me and letting me be a part of this amazing day. I mean, the talks have just been spectacular. I have learned a lot. Thanks for that slightly intimidating introduction, because I absolutely feel like I've just learned so much. I mean, I have been exposed to Dr. McKay's work and Dr. Ssewamala and Lucie's but Claude's, but you know, every time I hear them talk, I learn, 10 or 12 more things. And so again, it's a real honor to be here. So let's see. Do I just start my slides? I don't know if there's a special way to do it.
There's a special man behind the screen.
Aha. Special man behind the screen. Excellent. All right. Well, trying to think well, my first slide is my very boring government-issued title. And then I think I was just going to talk a little bit about NIH. I know some of you are very familiar with the NIH system, while others of you may not be as familiar. So just to give you a little sense, it's 27 different institutes and centers. So NIMH is just one of 27 different, institutes that funds research for the U.S. government. Aha, there we go. So I was actually going to start with an overview, but
Overview slides are boring. So here we are with the 27 different institutes and centers. So as you can see, NIMH in the pink is just really one of the institutes at NIH that funds research. So there are other institutes at NIH that do fund work in this area. In fact, a lot of the researchers in the room receive money from NICHD, from NIDA, from NIAID, who are good colleagues of mine who are also very involved and very interested in work in this area. So not only do I work within the NIMH, I work within the Division of AIDS Research at NIMH, so I just wanted to sort of put that out there because it does, the money that I oversee in the portfolio of grants that I fund does have to be tied to HIV, whether that's in the prevention of HIV infection or whether that's in research that's really trying to improve the health outcomes of those individuals living with HIV. But those are our two main goals. Research goals within the Division of AIDS Research at NIMH. And it includes both basic and clinical neuroscience of HIV infection. Don't ask me too much more about that because that's probably about where my understanding of the pathophysiology of HIV infection and the central nervous system ends. But we do have a number of talented program officers and scientists who work in that area. And then we also fund basic and applied behavioral and social science to prevent new infections and to limit the morbidity and mortality among those who are infected. And you can see more about our priorities on the website. So, this is another great part about going in the afternoon is that all of your points have sort of been covered already. So I can say, what's already been said, but what do we know? We know that focusing on individual level factors, whether you're talking about a young woman in Kenya or whether you're talking about a young man in South Chicago, just focusing on individual behaviors does not work alone. You have to take into account, it's not enough. You have to take into account other factors at the community level, at the partnership level, at the societal level that are impacting whether someone becomes HIV infected or whether they engage in care or whether they take their HIV medications. So we've really got a growing body of literature that's really looking at these social determinants. The World Bank or the World Health Organization has come out with a lot on social determinants of health. The CDC has come out with a lot on social determinants of health specifically focused on HIV. And I just wanted to include a few here, which again have been brought up already. We're thinking about stigma and discrimination. A big one of the what was it, the bad three, Lucie, in your model, stigma. We know that it really can affect participants' ability to adhere to antiretroviral medications. We know, obviously, economic factors play a big role in both HIV risk as well as in the uptake and
Okay, I'll be quick.
Well, thank you for not only your presentation, but for your work, because sometimes you don't know how far-reaching it is, so we learn from one part of the world and then we try to use some of these lessons in other parts of the world. But I rather wanted to make a comment than a question. So you mentioned about the so now we already know that some of the intervention components work for certain issues, and it seems like a lot of people are now interested in combining different components, and how do we test them? And you mentioned that do we have to do a 4 or 8 arm randomized trials, and I thought Linda Collins out of the UPenn Methodological Center, she is promoting this MOST approach, so multi-phase optimization strategy to interventions, so which allows you to test using factorial design. You can test different components of the interventions and how do they work, because she's basically using this engineering approach to social and behavioral interventions, because they said when engineers are developing something, if they know that 10 things work, they don't try to combine them all together. They can say maybe intervention 2 and intervention 5 would work together and you don't need the rest. So that's why I thought I would just mention it, because I think that would be an interesting way of applying this method to the work that you're doing, or many of us are doing, in terms of combining different components, but we're always limited by sample size, and it seems like this one doesn't require a huge sample size. We can just go away with the regular sample sizes we're using for like 2-arm trials.
It's a great idea, and this is something I'd love to discuss with people generally, because I'm really torn about this. You know, part of me thinks, let's use these great new innovative trial methodologies. I hadn't heard of that, this is great, but things like micro-trials and things. And then part of me thinks, it's so damn difficult to do an RCT in Sub-Saharan Africa. Like, it's an absolute bloody miracle if you just manage to have an intervention and a control group and you don't mess up too much. And then my worry is, the more complex you get, do you just end up much more likely to mess up? That's what I don't know. And actually, I'd love to hear if anyone's really successfully done one with a more complex design in Sub-Saharan. I mean, I know lots of failed ones, but I'd love to see some examples of successful ones and see what they did and learn from it. Because, yeah, that's just my worry, is that I would mess up. But maybe other people wouldn't mess up, actually. So, yeah, thank you very much.